Thank you very much, Pierluigi, for this invitation. I really appreciate it very much. Pleasure being here, old friends. Particularly nice to see Myron, Jean, all the others. Of course, it's so good having you here. So I'm going to thanks also Jessica for allowing me to switch and to talk earlier. This topic about downstaging is still fascinating. I would say on one side, and the other side is frustrating, if I may, because as you see, even though in the last 15 years we have been collecting evidences of any kind, but methodologically weak in a way, either in terms of numerosity, retrospective design, and any other. So we are frustrated in this. And in the clinical practice, probably more than 90% of our centers are totally devoted to select patient for downstaging and to actively downstage patient in real life clinical practice. So there is this kind of dichotomy between evidences and clinical practice. Now, I think that is worth to start from a banal and a classic classification of kind of downstaging, stratifying from relative and absolute. Relative is a kind of old methodology. To my eyes, this is just a personal impression. So the need to bring back to a certain criteria for transplantation the patient, and I will explain why to me is a kind of old patient. I am much more, fascinated by the concept of absolute downstaging. Absolute downstaging is the one that is aimed to, provide response to therapy, test the response to therapy, to a therapy pressure to the patient, which is actually, as Pierluigi was saying, a surrogate of tumor pathology. And in association with test of time, this is a nice, very nice selection process for patient undergoing liver transplantation to select the best biology to promote liver transplantation. So the test of therapy is an old concept. It goes back to this seminal paper, which is absolutely outstanding to my eyes, back to 2006. It was done by, as you see, independently from the macromorphological parameters. It was pretty clear that within or without Milan criteria, the fact that the patient was responding to a pressure of stabilization then was associated with fantastic results in terms of postoperative survival. And from that time on, we have paper going back to 15 years here in Italy, because at that time we had very high pressure in terms of epidemiological hepatocellular carcinoma presence in our settings. Envision the fact that the response to therapy was a nice way to select patients for any kind of procedure, even in particular liver transplantation. And you see how, for example, they published a study 10 years ago suggesting to exclude patients in progressive disease while waiting and while undergoing to therapeutic pressure. In this environment, the Vincenzo Massaferro study was developed, the one that has been so nicely depicted by Citerio. And to my eyes, that was a very difficult situation. I was not able to apply to this study because my ethical committee was considered this borderline ethically, because even at that time we were much aware about the fact that, not undergoing to transplantation would associate this patient to a bad destiny. And so I was not able to participate, but this is a seminal study. It changed completely our view, because he was able to demonstrate the efficacy in a randomized setting of downstaging. But moreover, the relevance of this study is the fact that it was one of the very first, probably a unique study, showing a randomized setting, which is the benefit in terms of gain life expectancies of liver transplantation if compared with alternative therapies. And we know, and we have to know, that the only relevant endpoint measure in liver transplantation is the gain in life expectancies, much more than the overall survival of 5 years, as has been considered so far. So one next step is, how do we monitor and we qualify a response to therapy? It is pretty obvious that we need to use mRECIST. I'm not sure that the penetration of this methodology is capillary, at least in our setting. We need to promote that, because if you use a nice and accurate evaluation in terms of mRECIST response, then it's pretty clear that you find out that the response to echoregional therapies is one of the strongest predictors of failure after transplantation, either in terms of intent to treat survival, either in terms of risk of recurrence and if you compare the risk of ACC recurrence post-transplantation for patients that do not respond to local regional therapies, is an odds ratio of 3 if compared to 1.3 for those patients that are even progressing while waiting. So this is, again, the therapeutic pressure is an incredible prognostic feature that we may use in our clinical setting. But now, a new methodology of defining the quality of response again in the play on the table. And these LIRADS, and some authors claim that when you have combination of regional therapy, for example, embolization and ablation therapies, they may be an advantage in using LIRADS in terms of evaluation of what has been the effectiveness of the therapy that you apply. And this is also true because LIRADS evaluate single nodules and not the overall burden of the tumor. The other evaluation issue, which is pretty well clear in the last 20 years, is the fact that there is still an incredible discordance within definitive pathology and what we evaluate at the moment of transplantation. Still 25% of the patients are upgraded according to the methodology. So that's the reason why relative downstaging is in a way still ineffective, because unless you use total tumor volume, which doesn't take into consideration small nodule, which are the one that may be tricky in the staging, you may lose patients, you may lose your accuracy in applying and including in one stage or another due to the insufficient accuracy of the methodology or radiology methodology before transplantation. Another piece of information which is important is a negative drawback of morphological evaluation, that you may have heterogeneity of response. You may have a mixed response. Some nodules may increase their proliferation after the therapeutic pressure, other may respond. And macromorphology is not a good tool. You may have same dimension, and maybe you can have a turn in terms of biological aggressiveness of the tumor. You're not able to counter with macromorphological features. This is very tricky when you evaluate treatment pressure. That's the reason why the perfect tool is a biomarker. Protein, I don't need to recall how alpha protein has been, game-changing in the last years. And you can see how, even though you have an all-comer in people with huge alpha-fetoprotein level, if you have a therapeutic pressure that brings back the patient down less than 100 and less than 20, even better, then you're going to have a very good profile in terms of results post-transplantation and risk of recurrence transplantation. This is the reason why the biochemical response is much more accurate in terms of biological evaluation of the response to downstaging if compared to the morphological evaluation. So we need to go in this direction much more than take into consideration the staging, the macromorphological staging, which is the problem here, that only a few prevalence of people are again having high levels of alpha-fetoprotein or even increased level of alpha-fetoprotein. We know that less than 50% of the patients has any change in alpha-fetoprotein. The tool is limited in terms of the population that can be used in. So we need to go in the direction of exploration and explosion pipeline of huge amount of biological signatures of the tumor, and Jessica will develop on that. We did it in the past, for example, exploring fetal mRNA and vascular endothelial growth factor in the capability to stratify patients according to prognosis in the setting of liver transplantation and after a pressure of 3 before transplantation. But again, this is a very important lesson for the future. We need to go in this direction in order to be more accurate. Another negative drawback that you have to consider, that the therapy is supposed to be complete as much as we can. Because a partial response is very risky. You know how an ischemic pressure may develop more aggressive clones, and this has been depicted and described in a number of publications. So even when you have a partial ablation or a partial chemoembolization, you can promote aggressive clones, and this may justify the proportion of patients then have unsuccessful downstaging, because you promote the evolution of an aggressive tumor instead of controlling the disease. So the whole things, we need artificial intelligence in order to increase our capability to intercept biology by morphological tools and by biochemical tools as well. How about the complete response issue? Should we transplant the people that has a complete response after downstaging? Well, the answer is yes, because close to 82% of the patients, even with a complete response, they still have clones, active clones at the pathological definitive evaluation. So these people is going to have, just a morphological response. It's not ever, it's very rarely a complete response. And indeed, you may control and reduce very much the risk for bout. And that's the reason why the intensive treat for the complete response is much better. But these people, these patients, to my eyes, deserve transplantation as well. With a low priority, however, we showed in this cancer publication by Alessandro Vitali, using the same setting of XXL, that when you do not, this is a retrospective study, when you do not transplant a patient that has a complete response to therapy, you have a profile of which is close to overlap the one achieved by transplantation. Clearly, the longer the follow-up, the better the survival, but at least from the point of view of transplant benefit and priority, you are supposed not to give priority to the patient with complete response, because they have time to wait, and you prioritize the patient that do not have alternative therapies available. So transplant benefit again first. How about relative downstaging? The reason why I don't personally believe in this push to get the patient into a predefined criteria, we are going to go in a world of heterogeneity. Some are going into the Milan criteria, other in UCSF, and into the tumor, and this is going to make even more difficult the evolution of this field. It needs homogeneous approaches, big numbers, and very repeatable settings all over, I think, the world. So, but this is my absolute personal interpretation, that arbitrary setup is increasing in the set of relative downstaging. Do we have, when we do a downstaging, the need for an upper limit? Superficially speaking, yes, because when you stratify according to this pathology, for example, a couple of years ago, you stratify according to the all-comers group versus a predefined UCSF downstage group. Of course, you have an intention to treat, which is better in brain if compared to all comers, and you have a greater dropout probability in all comers. But this is due to the fact that we are not able to interpret the biology aggressiveness in this population. And the bigger the burden, the greater the possibility to have patients higher biology aggressiveness. This is just an incapability to detect the patients with good biology, even within all comers. And the proof of that is the alpha fetoprotein power. Because again, in the all-comer setting for alpha fetoprotein, the results are absolutely overlapping to the people that has relatively low or intermediate alpha fetoprotein level. So it's a matter of how you look at it. To define anyway, if you wish, an upper limit, you can use, I think, this beautiful computational medicine example, which comes from Quirino Lai and Zhan. they were able to, find out within 10 variables that the number and diameter and alpha beta protein were impacting very much the overall statistics, and importantly enough, taking into consideration only competitive analysis, looking only to mortality related to the tumor, not the overall mortality, able to identify an area of relatively safety in terms of starting point, according to alpha fetoprotein and the sum of diameters and number of nodules, allowing to reduce the expected mortality below the threshold, arbitrary threshold of 30%, post-transplantation. That is supposed to be the one. With this setting, you expect a mortality related to cancer, which is 15%, which is a very good tool. And as you can see, the greater is the selection, the higher the probability to have a dropout. Because if you select a very tight selection process, then you risk to have a lot of patients that are getting out and dropping out while waiting. Quickly enough, in a paradox, if you include from the beginning very advanced tumor, BCLC, and even D in some instances, in this same thrombotic patient with neoplastic thrombus in the portal vein, you may achieve some results in the long terms, even though worse if they are clearly to a transplant, normal transplant setting. But again, should we look to the benefit or not? Even though you're going to have 50% survival of 5 years, then the alternative therapy is basically nothing, and you are going to achieve a huge amount of gain in life years. So my personal conclusion, if even in super downstaging, you have to consider transplant benefit in the context of your particular organ availability. Let's say living donation, let's say ABO group, let's say a very low pressure donor waiting list situation. Habeas rate is very variable because it's too much heterogeneous the way we treat. We downstage a patient. It goes from 40% up to 80%. Because the modality, the capability, the aggressiveness of the downstaging is different. I want to present this by Corte Giovanni Benarecci, this meta-analysis which recently done according to the old studies. And it's very easy to find how the successful is ranging between 35 to 87 again. But clearly the population downstaged has a great dropout if compared to the normal population transplanted for hepatocellular carcinoma. The tumor progression is greater again. The liver deterioration is even greater, maybe also as a matter of progression of the tumor. But at the end of the day, you're not going to have a worse outcome at 5 years. And this is according to all. So the success rate is extremely variable. So which is the best therapeutic tool in order to increase our homogeneity in terms to achieve good results in terms of pressure, therapeutic pressure? Well, I'm strongly supporting the minimally invasive approach. I don't have evidence here, unfortunately, because we are not being able to, put solid paper on the table. But I'm personally convinced that if you can treat potentially radical with resection in minimally invasive approach or with ablation in minimally invasive approach, you have a greater potential for iterative approaches, and you increase your probability to have complete response, which in turn is associated with a better results after downstaging, either in terms of lower dropout risk, either in terms of results, better results in terms of recurrence-free survival post-transplantation. But these need to be developed in terms of science in the future. As far as TACE and E290, recent gastroenterology and hepatology show that the potential for a partial response, not a complete response, a partial response is relatively high, close to 85% in this US study, even though the limitation of the study is that the follow-up is only 2 years, and we should take into consideration that. But clearly, the effectiveness, you can see how the curve is rising sharply, and this is a matter of efficacy. And these are useful tools, but again, probably the capability, and this is in the pathology shown, the capability to achieve complete response and in turn, to increase the efficiency of the downstaging process is probably lower if compared to potential therapies. But this needs to be demonstrated in the future. A completely different setting is now in the pipeline. Huge amount of protocols available in terms of systemic therapy. But here the framework is completely different. Now we are not testing the biology aggressiveness with these tools. We are treating the extrahepatic cells. So this is a real neoadjuvant approach if compared to the downstream, which is just a surrogate of biological aggressiveness. And we are not embedded yet these new protocols in staging setting. I will do it, I hope, as soon as possible. So as far as best therapeutic tool is concerned, I think that the therapeutic hierarchy is still in place here. Best to adopt, when possible, potential radical therapy and then select the other one. How long the test of time? Now here only expert opinion. 3 months is the one that has been set in many experiences, but no strong evidence is so far available. And no is also in the pipeline because no clinical trial gov study is including a clear focus endpoint on which is the weighting, which is the most efficient in this setting. So we need to be focused on validating that in the future. How about allocating issues present and in the future? Again, I don't need to recall how I have been dedicating the last 10 years to the benefit issue. Yano is one of the inspirators of that. And clearly, if you look at the benefit, the downstaging setting is the best one in terms of gaining life expectancy. That's the reason why in Italy, hepatocarcinoma undergoing to successful staging are stratum 1. So they have absolute priority because they gain a huge amount of life expectancies because they do not have alternatives in terms of therapeutic approaches. I go to my conclusion, sorry for the delay. Just citing the national guidelines recommendation, 5-year work, highly solid in terms of methodology behind this work, and thanks to Terry Trevisani for this incredible effort. The relevant PICO for downstaging is downstaging indicated in EPSOA beyond the oncological criteria, any oncological criteria, not only Milan criteria, any oncological criteria, using as comparator the non-transplant intermediate BCLC-B epsilon carcinoma. Only 2 evidence here. The one from the Mazzaferro study, the randomized clinical trial, and another one which is methodologically sustainable and in a way affordable from the grade point of view, which is this study comparing liver resection, oncological liver resection to the downstaging. You see how the benefit is very low and the difference. However, at the end of the day, at the end of the systematic review, the Italian multi-society group, 100 people, put a strong recommendation on adopting downstaging, even though based on low-grade evidence. This is my conclusion, saying that we need to have clear in mind, as Pierluigi was saying, that downstaging is just a surrogate tool for biology selection patients, nothing more than that. It's not a neoadjuvant therapy. You're not in most cases achieving any complete response, even though you need to have as a goal the complete response, because that accuracy in treating these patients increase your chances to perform better in the overall liver transplant setting and process. That independently from the clinical protocol, I am not hoping that we are going to achieve agreements in which is the best protocol to adopt. We need to improve the capability to predict biology, including in response to therapy, other cofactors of biology prognostic evaluation, as radiomics, as CAT scan, PET CAT scan, as computational medicine, data analysis on biomarkers, simple one, like, for example, neutrophil lymphocyte ratio, and of course, all that will come in terms of biomarker and cell biology insight, and Jessica will tell us about that. Systemic approaches are close out of the era, and we'll open a completely different era where we will use that protocol as neoadjuvant strategies in order to treat extrahepatic cells in order to increase our results post-transplantation. Thank you very much for your attention.
Thank you, Professor Cillo. Thank you, Umberto, for this lecture. I think that you have an institutional commitment in a few minutes. So as a chair of the webinar, just a brief question to you before you leave from the webinar. How do standardize the application of downstaging treatments to avoid to treat patients only with the in-house available treatments?
So the standardization is far to come, as you well know, and that's the reason for your provocative question, Luigi. But we have clear ideas and we have protocols. We don't use in Padova any upper limit for the selection process. Again, the process and the test of time is the most relevant piece of information you can get. So we go more than 3 months. And the reason why is that on top of it, we also have long period of waiting times, which is positive in that sense, because it prolongs the test of time. And then you increase your capability to select independently from the all-comers or upper selection limits. We aggressively adopt iterative protocols with minimal invasive approaches, as you know. We do laparoscopic ablation, and we biopsy the tumors in order to increase our capacity to stratify and to give more pieces of information about biological stratification. We use alpha-fetoprotein, we use neutrophil lymphocyte. In some borderline cases, we also use alpha-fetoMRNA vascular endothelial growth factor as the things that we have in-house. Any disease is out of the waiting list.